All right. Hi, everyone. Can everybody hear me? Are we good? Excellent. So I'm Dr. Escuro, Assistant Professor of Rheumatology at West Virginia University School of Medicine. This is our third talk, I believe. We've done rheumatoid arthritis, we've done gout, and I think that this may end up being one of the more maybe useful, hopefully, for everybody here talks, because hopefully I'll be able to demystify the use of ANA testing, when it's appropriate to get, how do we interpret some of these tests, and hopefully give you the tools to be able to know when to pick up the phone and say, hey, I think this patient needs to be seen yesterday. So let's get started. Learning objectives today, we'll review the clinical manifestations of systemic lupus erythematosus, or what we could just call lupus going forward. We'll learn how to interpret ANA results, recognize some of the non-rheumatologic causes of a positive ANA, and then hopefully be able to apply some of that understanding of positive ANA tests in order to triage patients for a rheumatologic evaluation. So the thing that I wanted to start off with is sort of 5 or 6 patient scenarios, all with positive ANAs. And when I do this, I'm not expecting you from the get-go to know, what disease they have or anything like that. It's not a read my mind type of thing. But instead, I just want you to think to yourself, based off of the story, are we worried about this patient or not based off of the ANA? So scenario number one, 75-year-old female with progressive hand pain for the past year. The pain is mainly worse at the base of the thumbs, and she's got this firm, bony swelling to her finger joints. She's unable to crochet like she used to be able to. That's been unfortunately really saddening for her. She's also been having worsening knee pain, especially as she goes up and down stairs. Maybe there's a little bit of puffiness to those joints too. And her past medical history is relevant for just blood pressure issues, for which is pretty well controlled on medications. An ANA is checked for her joint pain and it comes back as 1 to 160. So think to yourself, is that concerning or not? Patient number two, 60-year-old female with diffuse pain over the last 2 decades. Her medical history includes hypothyroidism, which is well controlled with levothyroxine, as well as irritable bowel syndrome. She has other symptoms such as significant fatigue, brain fog. And one of the more distressing things for her is that as much as she wants to be able to hug her grandchildren, whenever they come rushing over to give her a big hug, she sort of braces herself because she knows it's going to be quite painful with being hugged. Her ANA years ago was 1 to 80, and then it was repeated more recently and was 1 to 40. Scenario number three, 75-year-old male, very poorly controlled hypertension, and has a history of chronic kidney disease. His nephrologist has been trying to get that blood pressure under control. And so he ends up using a new blood pressure medication for this patient. Unfortunately, after this has started, he's now has worsening rashes and joint pain, and ANA was checked and it was 1 to 640. This patient was actually a real case. Those other ones I will say I made up for the purposes of this for this presentation, but this one was actually the daughter of one of my nurses back when in Myrtle Beach. So an 18-year-old female with a 1-year history of unintentional weight loss, lymphadenopathy, joint pain, and rashes. She actually has this really interesting story from when she was really young, where they thought that she might have an inflammatory muscle disease. There wasn't a diagnosis that came out of that, but they did find a positive HLA-B27. Inflammatory markers like a SED rate were elevated, but RA labs were normal. And occupationally, she works as a vet tech, and it was 1 to 80. Scenario number five, 22-year-old female. This patient has a history of worsening joint pain, pretty much all over the body. There's some swelling as well. She notes a rash on her face, seems to be worsening in the sun. And over the last couple of days, she's had some increasing pain in the right lower ribs, especially with deep breath. Review of systems also is significant for fatigue. ANA checked in is 1 to 640. Our last patient here, an 18-year-old male, completely healthy, getting ready to leave for college to be on the collegiate soccer team. And his only symptoms are that he is tired and maybe some lower extremity swelling. Eventually, an ANA is checked and is elevated to 1 to 2,560. So we'll come back to these patient scenarios. I'm going to give you a little bit of history in the meantime, as well as what lupus looks like. And hopefully we'll be able to apply some of our lessons to those cases. So unlike some of our diseases in rheumatology that we've just recognized over the last couple of years, like Vexus syndrome, I think we've mentioned here, maybe some immune checkpoint inhibitor related inflammatory arthritis, which has just been over the last decade or so. Lupus has been at least described since 400 BC is how far back we can go. With Hippocrates, we feel like he was talking about some of the oral ulcers as herpes estheomenos. From there, what we typically called the classical period up until the mid 1800s, we then entered, and that classical period was when the disease was just being described. That entered the neoclassical period where not only are we getting the description, but we're getting a better understanding of the manifestations and maybe some therapeutics. So as we enter into the 1800s and 1900s, we're starting to realize that there are some medications, whether it be like steroid-based meds, quinine, that these might be helpful for patients that have lupus. And then in our modern period of lupus, this is where we've really taken off in terms of more specific testing, changing that testing from a murine model in the 1960s to using more of a human epithelialized cell testing in the 1980s, and using these immunofluorescence assays to really be able to catch lupus earlier on in the disease process. And so a disease that has been known to us for thousands of years, and only now are we getting a better handle on how to manage it effectively. So what is lupus? So when it comes to lupus, we have things called just skin lupus or cutaneous lupus. A good example of that, as we'll see in here in a second, would be the singer Seal. If you remember Seal, he has that scarring on his bilateral cheeks. He didn't have systemic lupus, he just had discoid lupus that led to scarring. But for some patients with lupus, you can have the skin manifestations as a part of the body-wide lupus. So skin manifestations are a common thing that can be occurring. As you see at the top there, it can be present in up to 70% of patients. But then as you start taking a look at some of the other manifestations like arthritis, joint pain, 85%, so very common. But then as we start to go into the internal organs, you start to notice that it's not as common, whether it be hematologic manifestations, renal manifestations, neurologic manifestations, and then things involving the heart and the lungs. So when it comes to recognizing these patients with lupus early on, I think that one thing that comes to mind for a lot of people is what is described as the butterfly rash of lupus. Now, the term that we use in rheumatology is the malar rash, and a good example of that is on the left with the patient having this rash that spares what we call the nasolabial folds. So basically where you could see the area where you would be smiling, those creases, they tend to be spared with the typical malar rash. Now, the butterfly mainly involves the cheeks. It can involve the bridge of the nose, and it can even go up to the forehead. But as you move on to picture B there, this is actually an example of face rash involved with dermatomyositis. And so there's a little bit of difference between picture A and picture B here. There's still some of the cheek involvement. There's still the forehead involvement. But if you look past that black bar right around it, you'll notice that the eyelids are involved as well. And if you look back to those nasolabial folds, it actually looks like there's some involvement there too. And so this would be a more of a typical rash that you would see maybe in dermatomyositis. And then finally, in picture C, you have an example of a more benign type of rash, which would be rosacea. Now, it doesn't have quite as much of the intensity for us to fully tell the distribution of the rash. But if you look closely, you can see that that redness that is present on the cheeks and the nose is actually involving a lot of that upper lip as well. And so rosacea would be a much more benign indication, not related to systemic lupus, whereas picture A is very common, and especially in our younger patients with lupus. Now, when it comes to some of our more intense rashes, picture A and B are examples of discoid lupus erythematosus. And this is an example of what Seal had on his face. The unfortunate part with this type of rash is that it can be quite aggressive and quite scarring. So even if you do end up on appropriate medical therapies for discoid lupus, you could be left with a lot of the scars afterwards. Picture C and D just show the variability of subacute cutaneous lupus, or SCLE, that can be present. And you'll notice that this isn't just some redness, right? This isn't just some erythema over a thigh or anything like that. These are very aggressive skin lesions. And unfortunately, even from a rheumatology standpoint, there are so many mimickers for these types of conditions that it's really useful when we have some sort of skin or tissue biopsy that gives us some of our more typical findings that are reassuring that this is truly some type of cutaneous lupus. Now, on that path report, you might find something called interface dermatitis, which can be present in other conditions, but that's sort of our buzzword when we think we're dealing with the lupus rash. Now, alopecia is a common manifestation of systemic lupus as well. And if you look between pictures A and B, you might have some difficulty telling the difference between the two. Now, picture A is alopecia consistent with or present in a patient with systemic lupus. Whereas picture B is somebody who has lichen planopilaris or planaris. Sorry, I forgot the name specifically, but that's more of a dermatologic condition not related to systemic lupus. And so, if you asked me, hey, between pictures A and B, who's the lupus patient, without knowing more of their medical history or being able to look at the rest of their body, I wouldn't be able to tell you off the top of my head. And finally, Raynaud's phenomenon. I think that Raynaud's is something that frequently comes up as a potential autoimmune symptom that patients feel that they're experiencing. And oftentimes, patients are actually mainly talking about the picture that you see in C, where they see some redness to their fingers, especially with anxiety or with cold exposure. But the unique thing about Raynaud's is that you get this very distinct biphasic color change. So you have the blanching in picture A as the blood supply is cut off to the distal fingertips. In picture B, you get that duskiness from the cyanosis just from the fingertips being deprived of oxygen. And if you actually look closely, you'll see that this has probably been happening for a while because this patient has also developed some ulcers to their fingertips, which is suggestive of just long-term tissue damage from lack of oxygen. And then picture C is the reperfusion erythema, or the redness that comes as the patient is able to warm their hands back and blood flow returns to the extremities. So this is a typical finding in Raynaud's phenomenon. Raynaud's, I think, will be addressed a little bit later in the Echo lecture series. But the big thing here is that there can be two types of Raynaud's. Secondary Raynaud's, meaning secondary to something like systemic sclerosis, or what we used to call scleroderma and lupus, or primary Raynaud's, where it means that there's no underlying connective tissue disease and it's just Raynaud's phenomenon by itself. Sometimes we just call that Raynaud's disease. Now, moving on to the joints, oftentimes the joint pain that is present in lupus can be quite nonspecific. It's more of an achiness, but sometimes the advanced conditions end up looking like rheumatoid arthritis. So if you think back to our RA lecture, you might look at that picture A on the top there where you say, okay, I see some maybe ulnar deviation at the MCPs or that big row of joints. It seems to be going into the opposite directions. And I wouldn't fault you if you thought that this was an advanced case of rheumatoid arthritis. But this type of finding is actually a quite unique finding called Jacquard's arthropathy. And Jacquard's arthropathy is actually that these joint deformities are actually reducible. And so if you asked an RA patient with these joint deformities to make a fist, they wouldn't be able to because those joints are permanently deformed. Whereas in a lupus patient, it's almost like you've got double jointed joints and it just goes back to normal. So this patient is actually able to make a normal fist without difficulty. And this is a pretty unique feature of the type of arthritis that can be present in lupus. Now, these next manifestations are the ones that will oftentimes land patients in the hospital, unfortunately. And, lupus at its more mild or even mild to moderate disease activity levels can sometimes be difficult to diagnose just because of how many mimickers are out there. But as the patient gets sicker, it actually becomes easier to diagnose. So, for instance, if a lupus patient starts to get serositis or inflammation of like the sacs around the heart and the lungs, especially in the right population, like a young female patient, lupus tends to become upped in the differential. So, the example on the left is the excess fluid that's present around the heart within the pericardial sac. Unfortunately, can be advanced enough to cause tamponade. And on the right there, you have a pleural effusion. You'll see a sort of zoomed in level there where the fluid is in between the lung and the pleura itself. And that fluid, if you were to do some type of aspiration or a thoracentesis, would be quite inflammatory in nature and would probably show exudative qualities on Light's criteria. Lupus nephritis is something that can frequently lead to complications in our lupus patients. Unfortunately, it can lead to patients needing to be on dialysis long term and need a kidney transplant. But this is one of those cases where we're talking about biopsy proven disease where there's not much second guessing ourselves at this point. And so when it comes to lupus involvement in the kidneys, we have these different classification or classes that shows the level of how aggressive the kidney involvement is. And so we oftentimes miss class 1 and class 2 because the kidneys are not quote unquote bad enough to be biopsied yet. But when patients typically have like a urine protein creatinine ratio of over 500, they'll frequently get a kidney biopsy. And what you'll find oftentimes is either class 3 or class 4 lupus nephritis, what we would call focal lupus nephritis or diffuse. Class 5 is membranous, and there's a lot of protein loss in those patients. And class 3, class 4, these are all like glomerulonephritis conditions. And then class 6 is what we're trying to avoid. This is where you have more of a terminal prognosis when it comes to the kidneys. There's a lot of sclerosis in the kidneys, and unfortunately, there's not a lot going back from that level. So we're trying to act on class 3, 4, 5 when they're on biopsy. And sometimes we find class 1 and class 2 just because a kidney biopsy was done for other reasons. Now, there's been some talk lately, especially at the recent rheumatology conference nationally, where maybe we shouldn't be using 500 as our cutoff for when a kidney biopsy should be happening, and maybe we should be intervening a little bit sooner so that we can catch patients at class 1 or class 2 before they progress to some of the more aggressive kidney classes. Neuropsychiatric lupus actually tends to be some of our hardest ways to diagnose the disease or at least manage because there's such a wide variety of manifestations of the disease. It can affect the peripheral and the central nervous system. There are seizure disorders like PRES. There are some demyelinating conditions that can happen, aseptic meningitis. And then when it comes from a peripheral standpoint, you might be dealing with some peripheral neuropathies, but you might also be dealing with things that are more in line with Guillain-Barré syndrome. So unfortunately, we don't have great testing measures from a blood standpoint to prove neurologic involvement of lupus. Oftentimes, we'll rely on things like lumbar punctures and MRIs. And so up until this point, I'm sure even some of the non-clinical people here have watched TV shows, House comes to mind, even Seinfeld with George, where everybody's talking about lupus. And if you think about House, he always say, oh, it's not lupus, it's never lupus, things like that. And oftentimes, even if you talk to your local rheumatologist, they'll say, no, this positive ANA is not lupus either. And you might start convincing yourself, you've heard that it's never lupus. Could it actually be lupus? And so that's where we're really going to try to get into the nuts and bolts on how to recognize concerning features on preliminary workup where, the 2-month, 6-month, 9-month wait into rheumatology may be way too long to get that patient in. And that maybe we should be directly contacting the rheumatologist to save the patient an inpatient admission. So how do we do that? Does anybody recognize the symbol that's on the computer right now or on the screen? For some people, it might bring back some trauma, some expensive episodes in your past, if you think back to it. That is the check engine light. And so when it comes to the check engine light, you're driving your car down the street, you feel like there's something wrong with the steering wheel, maybe there's a knock in your engine, just something is wrong. And then the check engine light comes on and you say, I knew it. I knew something was wrong with this engine. And so you go to the mechanic, and before he pops the hood and take a look, he says, well, what brings you in today? And you say, my check engine light came on. He's like, yeah, but what really is wrong? Oh, sorry. And you explain the whole thing about what you're hearing, what you're feeling in your car. The thing is, if you just have the check engine light and you thought your car was completely fine, when you go to that mechanic, you're going to say, when he asks you, well, what's wrong with your car? And you say the check engine light's on, you won't really be able to offer up more information than that. You thought your car was completely fine. And so now if you think about it, that mechanic takes a look underneath the hood. They don't know where to start because all they know is that the check engine light is on. They may look around, they think everything is normal. Then you get your bill. It's for $1,000. You see the itemized receipt and it says check engine light problem fixed. You might think that you might have had one pulled over your head a little bit, right? You're like, he didn't really even fix anything. He probably just reset the thing. But if you knew something was wrong with your car, like there was something that they needed to be targeted, and the mechanic says, you know what, I think I'm going to start on this part of the engine because I think I know what's going on. The check engine light got you here, but I think I know what's going on. They pop the hood, they take a look, and sure enough, there's something abnormal. And so this example is really in line with how we approach ANAs. If you get an ANA test with a high pretest probability of a certain disease like lupus, then it becomes very valuable. You know what to look for. But if you get an ANA for something unrelated or maybe not as specific, for instance, generalized fatigue, even generalized joint pain, it doesn't actually end up being as useful. And so what is an ANA? An ANA is basically an indirect way to tell if something in terms of connective tissue disease is active or is occurring. And so there's two ways to test for an ANA. We in rheumatology have our preferences. We prefer the indirect immunofluorescence assay. What this basically is that we have a group of control cells that have these proteins or autoantigens that can bind to pathologic antibodies. And so we take this control cell line, we take the sample of blood from a patient that if they have an autoimmune disease, they've probably got some antibodies in there, and we just combine them. And so if the autoantigens in that cell line are able to attach to antibodies in the patient's blood, we then mix in this sort of like fluorescent detection antibody, which can only attach if the complex has been made, and then you can see it under immunofluorescence under a microscope. That is a positive ANA. The way that we don't prefer is what we call a solid phase assay. And basically all this is that you take the patient's blood, you put it on this like a plate of these this plate of antigens, and there's no Hep2 cell that's involved. And instead, you're just doing a mass check to see whether the ANA is positive or not. The reason why we don't like this test is that it's frequently where there's a high risk of false positivity. And on top of that, it doesn't give us a titer. It doesn't give us a number. So what am I talking about there? I'm talking about, before I get to the titer, I'm going to talk about the patterns. So you might have heard of patterns like homogeneous, speckled, peripheral, and nucleolar. There's some other ones like cytoplasmic and centromere. But these patterns can sometimes suggest to you what type of condition is going on. We'll go into more in depth in that in a second. Here's an example of the solid phase assay, or the other name would be like a multiplex assay, and it doesn't give us as much actionable information. So going back to our patient scenarios, you might remember when I said ANA was positive and I gave a number, right? 1 to 160, 1 to 640, 1 to 2560. I like to think of it like a ladder. The higher up on the ladder you are, the more concerned we are. The lower on the ladder, not as concerned. So what do these numbers actually mean? If we go back to that immunofluorescence assay where we were mixing the patient's blood with the cell plate line, you keep diluting the patient's sample to see how long it takes before that glow in the dark stuff starts to go away. If you have to only dilute that patient's blood 80 times, then that means it's a 1 to 80. If you have to dilute the patient's blood 2,560 times before before the fluorescence starts to disappear, that sort of implies that there must be a ton of antibody in there. And from that, we start to think that, okay, higher titers probably mean more antibody, which probably means the presence of a rheumatologic disease. Now those rules are not, fixed. There can be plenty of lupus patients with ANAs of 1 to 160. But I think what's even more important is that threshold of when do we actually start worrying or not. We only consider ANAs to be positive if they're greater than 1 to 80. Even some people will say 1 to 160, but 1 to 40 ANAs we do not feel are truly positive. Now, in terms of the patterns, I mentioned that there were a couple more like centromere and cytoplasmic. The cytoplasmic is a little bit of the black sheep of the family in that cytoplasmic really isn't present in the majority of rheumatologic diseases. It can be present in autoimmune liver disease, but it can be present in some inflammatory muscle diseases like dermatomyositis. So why does everybody then think of the ANA as the lupus test? The reason is because when you take a look at lupus patients, anywhere from 95, but really closer to 100% of lupus patients at the time of their diagnosis should have a positive ANA. The thing is, if you take a look at positive ANAs, you'll find out that patients with RA have ANAs, patients with Sjogren's disease have positive ANAs, scleroderma have positive ANAs, and even some diseases that are not rheumatologic, like Graves' disease or autoimmune liver disease or autoimmune thyroid disease. But the reason why it's been known as the lupus test, as I mentioned before, is because every patient with lupus really should have a positive ANA at the time of diagnosis. There is this idea of ANA negative lupus, which used to be a thing. That was before we really revolutionized the way we tested these ANAs by using these HEP2 cells. And so in modern ANA testing, you really should at some point have a positive ANA. The way that I explain it to patients is that, just because you have an ANA doesn't mean you have lupus, meaning just every apple is a fruit, but not every fruit is an apple, right? And so it doesn't go both ways. There are other conditions that can have positive ANAs as well, multiple sclerosis, malignancy, infection, and we've even found positive ANAs in patients with fibromyalgia. Again, not saying that ANAs are causing fibromyalgia, it just goes to show how common these ANAs can be. Now, for the longest time, like I mentioned before, we think that high ANAs are more concerning and low ANAs are not. And so there was this study that was done out in Belgium where they looked at the registry of these patients. A lot of things are centralized over there, where over 10,000 patients had ANAs that were tested. And they looked at something called a positive predictive value, meaning how likely was it with a positive ANA that it led to a diagnosis of a rheumatologic disease after the patient was evaluated by multiple rheumatologists. And so taking a look at our different ANAs, an ANA of 1 to 80, that's that in the top left corner. It's a little small, sorry. But the positive predictive value of finding any autoimmune systemic rheumatologic disease, that's that AASRD, for any of these patterns, homogeneous speckled nucleolar, was anywhere from 2 to 4%. So 2 to 4% of the time for patients with an ANA of a 1 to 80 titer, you only got a rheumatology diagnosis in the single digits. Now, if you start to multiply that and you go from 1 to 80 to 1 to 160, that 2 to 4% now transforms into anywhere from 6 to 30%. Do it again. 1 to 320, anywhere from 11 to 42% in terms of the positive predictive value. 1 to 640, anywhere from 30% to 77%. And once you get to 1 to 1,280 and above, anywhere from 40% to 80%, depending on the pattern there. And so you'll notice, as I mentioned before, that the titer seems to really help when it comes to, and the pattern helps when it comes to predicting whether this is a true rheumatologic disease or not. Now, some takeaways from here is that even in the centromere pattern that has that 82% positive predictive value when over 1 to 1,280, most of the disease ended up being systemic sclerosis or scleroderma, but it's still not 100%, right? And so it's still not, I said 76%, sorry, there it's 82%. Even at those really high levels, it's still not 100%. So even a patient with a really high titer ANA, even with a centromere pattern, doesn't automatically mean they have the disease. And so what this really does is just hopefully addresses that we shouldn't over rely on these types of testings, the ANAs. So what should we rely on, right? What's more specific then? And so if we go back to that analogy with the mechanic, you think about, okay, sometimes they pop the hood, they take a look and they're like, I'm not sure. Let's run the computer. And you run the computer and it starts pumping out diagnostic codes like error code E101. And you say, oh, this has been coming through a lot lately. There was a recall and things. We just need to replace this part. We know exactly what's going on. And so our error codes in rheumatology end up being the specific antibodies. And it's a little bit of a busy slide. This was made by a friend of mine back from college. He's now a rheumatologist at Duke. But he makes these nice sort of one pagers that gives us a lot of information. So taking a look at the top left, lupus, we have very specific antibodies for lupus, the double-stranded DNA antibody, the anti-Smith antibody, and sometimes even some of the antibodies from other diseases, like the Sjogren's antibodies, the SSA and the SSB antibodies. You take a look at mixed connective tissue disease a little bit further down in the green. That's the anti-U1RNP antibody. As we talked about in a prior lecture, we have our rheumatoid arthritis antibodies, like the rheumatoid factor and the CCP antibody. Scleroderma has its own specific antibodies, like the anti-centromere and the SCL70 antibody and RNA polymerase 3. So these antibodies, although we don't rely solely on these antibodies as well, are much more useful when it comes to making the diagnosis than just saying a positive ANA. So bringing it all back together, then how do we actually make the diagnosis? Now, these are what we call classification criteria in lupus. So we don't typically use them like to a T for clinic medicine. This is more for like research purposes, but we still use this general framework. In that on the left in the blue there, you have your clinical domains like symptoms, signs and symptoms. And on the right, you have the purple areas called the immunologic domains. And ultimately, if you look at the inclusion criteria in the bottom right there in the green, patients have to have an ANA of at least 1 to 80 to even be considered for a lupus trial. Again, these are not diagnostic criteria, these are classification criteria. The other thing is that you need over 10 points. And so taking a look at the blue there, you'll see that there are some things like fever that gets you 2 points. Whereas if you go all the way down to the bottom, you'll see 10 points for class 3 or class 4 lupus nephritis. So there's some weight behind these things. Why? Because some things are much more specific for lupus than others. If somebody has fevers that have been unexplained, but you find out later on that it's not lupus, but it's something called Still's disease, well, the fevers weren't really lupus related. So it's only 2 out of the 10. Whereas class 3 or class 4 lupus nephritis, the pathologist is just making the call. I see lupus in the microscope, and therefore you can automatically make the diagnosis. But taking a look on the right there in the purple, you'll notice that those highly specific antibodies that we just talked about, like the double-stranded DNA antibody and the anti-Smith antibody, those are only worth 6 points. And one key here is that if you have points from the same domain, like if you had both a double-stranded DNA antibody and a Smith antibody, you don't get 6 points for each. You only get 6 per domain. So if you have somebody with a Smith antibody, that's 6 points. A low C3, that's 3 points. Not low C3 and C4, but just low C3. That's 9 points now because 3 plus 6. And then let's say that they have a history of low white blood cell counts. That's 3 points. So overall, you have 12 points. You would be accepted into a lupus research trial. Now, why are they such sticklers about who they let into these trials? Because you don't want to have non-true lupus in the trial that might lead to the FDA approval of a new medication. If you have patients that don't meet these criteria, but they actually end up having rheumatoid arthritis, and you find out that that patient doesn't respond to this experimental med for what you thought was lupus, not that it doesn't treat lupus, it just, you might be trying to treat the wrong disease. And so these are quite strict criteria. So we don't hold it to like an absolute must. So there's this idea of a false positive ANA, and I really try to avoid this term because false positive almost implies that like there's something wrong with the test or there was an error in the test. And the thing behind a false positive is just like, at this point, I don't see any evidence of a systemic connective tissue disease, but that doesn't mean that it might not develop 5 years from now or 10 years from now. Maybe we just checked you too early. And the other thing that we have to keep in mind is that the frequency of these ANAs being positive increases with age. So it's almost like an expectation. Now, positive ANAs can be present in anywhere from like 10 to 20% of the population. Some trials even say 30%. Now, what about the false negative ANA? As I mentioned before, for lupus, you shouldn't really have these false negative ANAs anymore. But for other conditions like Sjogren's disease, there's this basically scenario where sometimes there's not enough antigen on that control cell line to bind the SSA antibody. And so if you actually directly tested for the SSA antibody, that it would actually be positive. So the take-home point there is that if you're concerned that a patient has Sjogren's, maybe just not getting the ANA, but getting an SSA antibody along with it would be helpful. But also the reason, the idea behind a false negative ANA doesn't mean, that it's truly falsely negative. It's just that some diseases don't have ANAs. Like rheumatoid arthritis patients, 50% of them have positive ANAs, 50% don't. But you could have a positive rheumatoid factor or a positive CCP. A disease like vasculitis can have a positive anti-MPO and PR3 antibody, but have a negative ANA. So you really need to know what you're getting into when you're testing, like which disease are you suspecting could be present. Other workup to consider, patients with hypothyroidism can have positive ANAs because of an antibody called antithyroid peroxidase or TPO that will cause a positive ANA to occur on testing, but it's not due to some type of disease like lupus. Instead, it's the reason behind why that patient has hypothyroidism. And then in the GI world, autoimmune liver disease or autoimmune hepatitis has certain antibodies like the mitochondrial and smooth muscle antibodies that could be tested for as well. And so just again, thinking, why is this ANA being obtained? Is it because of liver dysfunction? Is it due to thyroid dysfunction? Or is it due to things like kidney dysfunction? Take home point here too, and I think we addressed this in prior lectures, is that, honestly, if your pretest probability is high enough to order an ANA for joint pain, then you should be getting x-rays of the affected joints along with inflammatory markers as well. And it's specifically for RA testing for that rheumatoid factor and CCP antibody that we talked about previously. I'm not going to go over this whole chart. This is just how we treat lupus in rheumatology. But some of the take-home points here is that if you take a look at the top of the chart, hydroxychloroquine is our go-to medication. Hydroxychloroquine has shown that patients with lupus have fewer hospitalizations, fewer or less chance of having renal involvement, and it also even improves mortality prognosis. Now, things to keep in mind, though, is that outside of hydroxychloroquine, there are scenarios where you don't actually need to immunosuppress the patient. So, for instance, low white blood cell counts don't always require immunosuppression. If you take a look at the bottom middle there under neuropsychiatric, where it says cognitive dysfunction, if somebody has brain fog, that doesn't necessarily mean you need to immunosuppress them as well. Hydroxychloroquine ends up being sufficient. Now, you'll know that we use a lot of prednisone in rheumatology because it tends to decrease inflammation very quickly. But our recommendations in the rheumatology world is that we're trying to get to 5 milligrams or below, that we feel like that is a more acceptable dose rather than keeping somebody on like 15 milligrams indefinitely. So going back to our patient scenarios, patient scenario number one, now that we know what lupus looks like, now that we know what ANAs are concerning and not concerning, let's think about, are these patients that we should be sending or picking up the phone to call rheumatology immediately? So ANA 1 to 160, 75-year-old female with hand pain. The disease that I was actually sort of, trying to imply here was osteoarthritis. That's why she can't crochet anymore. And that ANA is not clinically significant. The ANA did not cause her osteoarthritis to occur. Scenario number two, a 60-year-old female with the diffuse pain, IBS symptoms, significant brain fog, and fatigue. This disease sounds more like fibromyalgia. It's really reassuring that the patient years ago had a low titer ANA and it was rechecked and it was low again. It didn't even hit that 80 threshold anymore. And so over the years, the patient did not end up in the hospital or have end organ damage. So it is unlikely that it is related to connective tissue disease. We do not obtain ANAs for what we already think is fibromyalgia. Scenario number three, we were talking about the scenarios of lupus previously, or the symptoms of lupus. And typically lupus patients are young female patients like Selena Gomez, who had a kidney transplant by the age of 24. This is a 75-year-old patient with worsening rashes and joint pain. Now, the ANA is high at 1 to 640, so I am concerned, but it's not the systemic lupus erythematosus that we've been talking about. This is a case of drug-induced or medication-induced lupus. And likely what happened is that the nephrologist started a medication like hydralazine, which is known for causing drug-induced lupus, and that's why the patient's getting worsening rashes and joint pain. That real case scenario of the daughter of my nurse from my last job, you look at this and you say, it's hitting all the check marks, right? 18-year-old female, unintentional weight loss, swollen lymph nodes, joint pain, rashes, elevated inflammatory markers. Surely this is our first example of true lupus. It was interesting, though, because her primary care doc, it wasn't even me, but her primary care doc, after I evaluated the patient, there were no signs of lupus antibodies. She said, you know what? You work as a vet tech. Have you had any cat scratches lately? Sure enough, she did. And they got some testing for that. And what they ended up finding was that she did not have lupus. She instead had cat scratch disease. She was treated with azithromycin, and that year-long group of symptoms of weight loss and lymphadenopathy and joint pain completely disappeared. So although that ANA, or although that the patient truly had a medical condition that needed to be treated, the ANA actually was not related to a rheumatologic disease. It was related to infection, most likely. 22-year-old female, widespread joint pain, rashes, chest pain, which ends up being probably like a pleural effusion. ANA is high at 1 to 640. This is likely systemic lupus. That ANA is clinically significant. And now our 18-year-old male patient, this patient was a true patient as well. I saw him back in fellowship. You went into his hospital room and you're thinking, man, this, he looks fine. He's not really having symptoms. How did he end up in the hospital? When he went to urgent care for this fatigue and this extremity swelling, his creatinine was 6 and his potassium was 6. So he was in complete kidney failure. His ANA, while they were waiting for a kidney biopsy, came back really high at 1 to 2,560. And if you think back to that chart earlier about how likely it is that he has a disease, it's over 50%. That kidney biopsy showed class 4 lupus nephritis, which basically just proves body-wide lupus. Unfortunately, from there, he did require dialysis and cyclophosphamide, so like true chemotherapy. Unfortunately, after that, he developed a seizure disorder and was diagnosed with macrophage activation syndrome. So he was readmitted to the hospital. We thought he was going to pass away, but thankfully he didn't. And I remember from when I first met him, his dad said, I'm going to donate my kidney to my son. And I said, sir, it's not that straightforward. We have to make sure you're a match. And sure enough, his father eventually diagnosed him, or eventually donated his kidney to his son. And he still sends me text messages of his son playing soccer. And every time I see him take a dive or something, I always get so worried that his transplanted kidney is going to get messed up or something, but he's doing great now. And so one thing that I wanted to end with is actually just one final case. And I think that this sort of shows about the future of rheumatology and what we're excited about. So if we think about any patient that we see as a new patient or a transfer patient in our clinics, not even rheumatology related, you're looking at the initial paperwork and you look at the medication list or you look at the problem list. And in rheumatology, we oftentimes do this if a patient, has come from a different rheumatologist and we say, oh man, look at that past med list. Patients already tried hydroxychloroquine, high doses of steroids. They've already been on chemotherapy like cyclophosphamide. They've tried the new stuff like belimumab or Benlysta, the first FDA-approved medication in lupus for 50 years. Hydroxychloroquine was FDA approved in 1958. Benlysta was approved in 2011. So we went 50 years without an FDA-approved med, and she's failing that too. You take a look at her medical history. She's had biopsy-proven class 3 lupus nephritis. She's had a history of inflammation around the sac of her heart. And then she has a history of even the type of vegetation on the valve or non-infectious endocarditis, Liebman-Sachs endocarditis. So this is a complicated patient, clearly. Unfortunately, she has tried and has failed all of those treatments. So this case is actually real. This patient was 20 years old over in Europe. And at this point, the rheumatologist just had no other options for this patient. There had been, though, very exciting research that had been done in the treatment of certain lymphomas for something called CAR T-cell therapy. And CAR T-cell therapy is something that we do here at WVU for treatment of certain leukemias, lymphomas. And it has really changed the game in terms of the management of those patients. But some of the preliminary data from some of the bench research type of things said, you know what, this might be useful in lupus as well. And so in terms of a compassionate use type of intervention for this patient, it was not FDA approved or even approved by the European body to use CAR T cells in lupus patients. But they decided we don't have any other treatments for this young woman, and so we're going to try it. And so what they ended up finding is that after starting CAR T-cell therapy, her lupus completely disappeared. And so in the time since then, they have repeated this in other lupus patients as well. So what is CAR T-cell therapy? Basically, you take the blood out of the patient, you sort of harvest their T cells, you reprogram those T cells, you infuse them back into the patient after they've gone through some chemotherapy to wipe out their bone marrow. And then when those T cells go back into the system, they can target a certain cell that you think is causing issues. In the oncology world, they've used it for things like B-cell lymphomas, but in the rheumatology world, we used it to target these CD19 B cells, which we thought contribute to active lupus. And we said, if we get rid of the cells, maybe we get rid of the lupus. And that's exactly what we found. So in the short term, at least as of 2024, when we got an update, they have now tried this CAR T cell therapy on 8 patients. And in the short term, their disease activity scores went to 0. These were all very sick lupus patients, all with lupus nephritis, all of them on chemotherapy, all of them on immunotherapy. These are patients that didn't have anything else to go for in terms of treatment, and they are now all in remission. And the crazy thing is, none of them are on prednisone, none of them are on any immunosuppression, and they've taken even hydroxychloroquine away from these patients, and it's still gone. Now, if you take a look at the bottom left, these patients, as far out, that initial patient, at 2 years, the lupus is still gone. The disease activity score, that SLEDAI-2K, 0. The double-stranded DNAs, 0. The complements, back to normal range. Urine protein, 0. And so we're really reaching this point where we have described to patients for years when they ask, do I have to stay on my RA meds or my lupus meds forever? We have always talked about that we are just trying to get somebody into remission using meds. We can't cure the disease. And yet now we're looking at cases of the sickest of the sick lupus patients. Now going through CAR T cell therapy is, no easy task. It's expensive. It could actually be life-threatening because you can get a lot of reactions with the treatments. And yet we have found that maybe some keys to getting rid of it, maybe for the long term. So we're entering a period now of like a new phase. If we go back to that initial slide about the different types of periods of time of lupus, are we now entering a new phase of lupus where we're not talking about just treatment, but we're going to be talking about cure in the near future? So it's a really exciting time. So with that, I wanted to say thank you for your attention. If you have any questions about positive ANAs, I'd be happy to answer them. If you have any patients that you just wanted to discuss in terms of disease activity, I'd be happy to do that as well. And I think Dr. Rexford is here. Yes.
I'm just curious. I have a patient who is a 78-year-old gentleman with chronic kidney disease and history of prostate cancer and diabetic, a whole lot of other things. And I'm just wondering, I mean, he's had a positive ANA at 1 to 540. What effect do all of those other things have on that ANA?
Yeah, so the things that I would be wondering based off of that medical history would include how active is you said prostate cancer? Is that correct?
Yeah.
So malignancy, if you tested everybody at the cancer center for ANAs, I assure you it will hit greater than 50% because malignancy causes positive ANAs. With the chronic kidney disease, much like our patient scenario number 3, is that patient on hydralazine to control his blood pressure because that's typically, it's not, okay. Antiarrhythmics like procainamide, patients undergoing latent TB treatment, you always think about drug-induced lupus.
Yeah.
Other things you would worry about would be, again, with how active his disease is or how active his malignancy is. We have run into over the last 5 to 6 years or so these immune checkpoint inhibitors, where, for instance, if you've heard of the medication pembrolizumab or Keytruda, it's like been a game changer for things like lung cancer, breast cancer, kidney cancer, and yet it induces rheumatologic conditions. And actually, the interesting thing there is that they think that that's a sign that prognostically that the patient will do better from a cancer standpoint if they're running into all these issues from like side effects. It means the medication is working. And so it's the whole idea actually behind using mRNA vaccines as a type of cancer vaccine, where if you actually give them an mRNA vaccine before their treatments, that they'll actually respond better for their cancer treatments. That's an aside. Sorry, I'm a little tangential here, but
Interesting though.
yeah, it is. And so you wonder whether it's not so medication induced from like the typical stuff like hydralazine and antiarrhythmics, but depending on the chemotherapy, if it's an immunotherapy, is it something from there? And then the elephant in the room is this just a person that's 75 years old and has a positive ANA?
Yeah.
And that's why we don't rely on the ANA specifically. Now, in real world medicine, if somebody has joint pain and they've got a high ANA, will I use that as an opportunity to maybe put them on some hydroxychloroquine as a trial to see if they get better? Sure, we do that on occasion. If we don't have a specific diagnosis of lupus or RA. But anything past that, we worry about trying out our meds because they're all immunosuppressants. And so if my goal is to make somebody have their wrist pain improve or their fatigue improved, but I'm putting them on methotrexate or something more intense, and now they have liver dysfunction and blood count drops, like that wasn't worth it, right? And so the ANA, it's a good screening test. One other analogy that I often use with patients is that it's like a mammogram. If you get a mammogram and there is an abnormality on that mammogram, we do not jump straight to a breast cancer diagnosis. We say, now we have to do further testing to prove it. And I would be surprised, my father was an oncologist before he retired. I'd be surprised if he went off a single mammogram and said, it's time for you to treat breast cancer. You're like, no, way too early. We're just getting started in terms of the workup. So we use the ANA in a very similar way. For a test that has a high sensitivity, but maybe a lower specificity, it gets you in the door. And that's why it's like, okay, if we're worried about lupus, there should be a positive ANA. And so I will say that with the caveat, just 2 months ago, I had an 18-year-old female patient with a typical malar rash, inflammatory joint pain, a normocytic anemia that looked like it was not related to anything like an iron deficiency or anything like that. And she had a negative ANA. And so you could just go about based off of the rules, right? Like, can't be lupus. But that's where your clinical suspicion hopefully is high enough that you say, I'm going to check it again because I would have put money on this, that this is lupus. And sure enough, it was. ANA came back as 1 to 1,280, double-stranded DNA through the roof, Smith through the roof, low complements. And unfortunately, she got hospitalized for low blood counts. She's on high doses of steroids. She's on immunosuppressive therapy with Benlysta. And so sometimes you are surprised, but not surprised. You're surprised that the ANA is negative. You're not surprised when it comes back as positive. And there's some lab variability there too, right? There is a human component to an extent in terms of a person interpreting some of these ANAs. You don't want to blame every negative ANA on that. But it's really where we hope that we're not just getting ANAs to get them as almost like a screening tool for all of our patients, but instead it's very directed. Inflammatory symptoms, I'm willing to put some money on this, that this is going to be RA or lupus, so therefore I'm going to get this test. And so then when we send it off to rheumatology, we're like, I thought it was lupus and the ANA is positive, so I'll see if they agree or something like that. I had a colleague of mine back at my last job that for anything, like knee pain, he was getting things like vasculitis panels because you could get them. And so when you get like a MPO antibody for ANCA vasculitis and you ask why the test was obtained, and they said, because my knee hurt, you're like, now it just introduces a lot of confusion, right? Like, what do we do with that antibody? The kidneys are fine, the lungs are fine. Am I going to immunosuppress you for a disease that I can't even find yet? And so sometimes we just try not to open Pandora's box, right? And we wait until the story makes sense.
I feel like that happened with this gentleman. I was badgered into doing the ANA by a wound care
Mhm.
colleague who was concerned about the appearance of his legs and thought he might have scleroderma. Those tests were fine. His SED rate's
Mhm.
elevated, but he's got enough other reasons to have an
Right,
elevated SED rate. CRP is negative or
right.
normal. So I'm skeptical of the lupus, quite honestly.
Yeah, no, I completely agree. Now, again, positive ANAs could be more than that, right? There's like the whole question of scleroderma. But, really from that standpoint, you said the ANA was positive, correct? So
Good.
we're sort of stuck with it, but that
Yeah.
would be a very reasonable, rheumatology referral, just saying like, hey, I have a patient with leg wounds. Somebody out there thought it was scleroderma. I'm not really seeing it, but the ANA is positive, and we can go in, we can further assess that.
Yeah. Well, I've made a local referral and his appointment's in
Yeah.
October 26th.
Oh gosh. And this could be a whole nother um, unfortunate problem or a whole nother presentation. But back in 2015, we did a workforce study where it showed that as the population gets older and sicker, and we know more about rheumatologic diseases, you would hope that the number of rheumatologists is increasing, but it's actually decreasing. And that's much like if you think of NASA and the brain drain when, like, the Apollo program stopped and you didn't really have people who were in the control room to send people to the moon. And now we don't really know how to send people to the moon anymore. It's very similar. And so we're trying to claw our way back in terms of training rheumatologists, but there's a heavy need, unfortunately.
Yeah. Well, I appreciate your insight about his results.
Yeah, yeah, I think it would absolutely be a reasonable. I think, um, if there was a question about scleroderma, maybe getting some of those antibodies like the SCL70 and this centromere antibody would be appropriate. But um, I would agree that, a man that old, at that age, I wouldn't say that this would be typical systemic lupus. Um, but if the specific question was for scleroderma, I would be curious what the centromere and the SCL70 look like.